Good morning, everybody. My name is Katie, and I'll be presenting a policy analysis on expanding nurse practitioner prescriptive authority. Many states continue to restrict nurse practitioner prescribing abilities, limiting their capacity to independently prescribe medication, including controlled substances, which affects access to timely and efficient patient care. So my policy question is, what policy model best supports the implementation of full prescriptive authority for nurse practitioners to optimize care, efficiency, and quality of care? So as the background, we know that states that limit nurse practitioners' prescriptive authority tend to face wider health disparities, such as increased chronic disease prevalence, reduced access to primary care, and higher medical costs. Strong evidence shows that NP-led care provides outcomes comparable to physician-led care. Many states continue to have a require physician supervision or collaborative practice agreement for nurse practitioners to prescribe medication. Prescribing medication in a timely manner is crucial in providing quality of care and improving patient satisfaction. So, prescribing authority for nurse practitioners varies depending on individual state laws and regulations. In the state of Missouri, nurse practitioners must complete 1,000 hours of supervised practice plus 300 hours of direct in-person supervision with collaborative physician before practicing independently within the collaborative agreement. Also, physicians should be available 24/7 via telephone or video call, and also they must be located within 75 miles of a nurse practitioner's practice site. Additionally, the physician must review 10% of the nurse practitioner's patient's chart. Social and economic challenges we have. So rural population experience very high rates of chronic disease, increasing the need for consistent and accessible primary care. However, in rural regions, we don't have so many primary care physicians available to see those patients. So when patients have comorbid conditions such as diabetes or asthma for management of those chronic diseases, because they cannot find a primary care provider, which is a physician, they usually go to emergency departments, which increases healthcare costs, and also those restrictions for nurse practitioners' prescriptive authority limits nurse practitioners to prescribe medication for those patients to manage their chronic conditions. So I have three policy alternatives here listed. So first one is transition to practice model. This model will allow APRNs to gain full practice authority after completing 2,000 hours of documented collaborative practice with physician. Second one is expansion of controlled substance prescriptive model, which APRNs gain independent authority for Schedules 3, 4, and 5, and conditional authority for Schedule 2 medications, which in this case, physicians still required to watch them on high-risk drugs or initial prescribing, but still nurse practitioners can perform assessment, diagnose, and develop treatment plans, which includes prescribing medications for those who are critically ill or oncology patients. And third one is, I think it's the best policy, full prescriptive authority, which is in this model, it removes all physician collaboration requirements immediately for qualified APRNs. which grants them full and independent prescriptive authority for all medication classes within their scope of practice. Currently, Colorado, Arizona, and Iowa has full prescriptive authority. I think this is the best policy for nurse practitioners because since we can assess, diagnose patients, we should be able to treat and prescribe medication for our patients. Key stakeholders would be Missouri State Legislature, American Association of Nurse Practitioners, State Nursing Board, and patients in community members. So in conclusion, I would like to say that expanding APRN prescriptive authority is critical for improving patient access to healthcare, particularly in underserved and rural communities. So by engaging legislators, professional associations, healthcare administrators, and community members through tailored strategies, we can increase the likelihood of successful policy implementation and long-term impacts on healthcare delivery. I also included my reference page here, and my infograph talks about statistics and why this policy matters in St. Charles County in Missouri. And I also included references on this. Thank you for watching. I hope you enjoyed it.